Cystoscopy is the most common urologic procedure. It can be performed in the operating room, the endoscopy suite, and most frequently in the office. Both diagnostic and therapeutic procedures can be performed with minimal anesthesia in the office setting. The Vision Sciences EndoSheath cystoscope consists of two parts, the reusable endoscope and the disposable endosheath. The endoscope includes the body or handle and a flexible shaft. The tip deflects 220 degrees in one direction and 180 degrees in the opposite direction. The optical system consists of a CCD chip located at the tip of the shaft. Illumination is delivered from light-emitting diodes within the endoscope. On the handle, a thumb lever controls deflection. A two-button system controls irrigation. 4 buttons on the handle can be programmed to control camera functions including brightness, contrast, resolution, and recording. These functions are programmed on the control unit. For use, the endoscope must be mounted within the selected endosheath. The EndoSheath system is packaged as a one-piece, ready-to-use unit. It consists of a sterile barrier drape which is mounted onto the specifically designed holder. The selected endosheath is then mounted within the drape with the accessory port facing out. The endoscope is then placed into the sheath carefully to direct the tip into the D-shaped endosheath connector. Aligning the locking knob with the slot on the connector assures proper positioning of the tip within the clear lens at the end of the endosheath. The endoscopic image can be followed as the tip enters the lumen of the sheath to assure proper positioning. If the tip of the endoscope is not positioned correctly in the shaft, it should be withdrawn and repositioned. If any debris is seen in the visual field, the endoscope should be withdrawn and the tip cleaned. Rotating the locking knob on the scope clockwise 90 degrees secures the cystoscope to the endosheath. The irrigation tubing is then placed into the channel on the handle. The base of the shaft and the handle of the instrument are then covered with the wider portion of the endosheath. Irrigation fluid is connected to the irrigating port and the instrument is ready for use. Two on-off buttons on the handle compress or release the flow of irrigation. The endosheaths are available in two designs. The diagnostic sheath includes a smaller channel. At 1.5 mm in diameter, it is adequate for irrigation in 3 French devices. The operative sheath has a 2 mm channel, which is adequate for irrigation and larger working instruments. We can demonstrate the use of the cystoscope, the endoscopic images, and the delivery of the instrument into the visual field in actual use. The first patient is a 65-year-old man with a history of bladder tumor, who is managed with routine cystoscopic surveillance. The urethra, prostate, and bladder are visualized. There is evidence of scarring from previous tumor resections, and both orifices are seen. Note that the orientation in the videoscope is related to the camera at the tip of the endoscope. The 6 o'clock position at the tip is always in the 6 o'clock position on the monitor. The image does not rotate with rotation of the endoscope as seen with the rigid cystoscope. The second patient had a stent placed before shockwave lithotripsy. Now, after the fragments have cleared, the stent is removed. After the endoscope and sheath are placed into the bladder, the stent is visualized. A 2 mm endosheath is used to accommodate the 4.5 French rat tooth grasper. The grasper is placed under the stent, which is removed without difficulty. In the third patient with a history of bladder tumor, a small recurrent lesion is identified. The 5 French biopsy forceps is passed through the channel to biopsy the tumor. A 3 French electrode is then passed to coagulate the remaining tumor and the base of the lesion. Direct inspection shows that the entire lesion has been treated and there is no bleeding at the completion of the procedure. This endoscope sheath system offers several advantages over conventional endoscopes in the office setting. There can be rapid turnaround between cases, there is no risk of chemical contamination, a sterile surface is in contact with the patient, it provides an excellent endoscopic image with a good working channel.